I am so pleased to introduce our speakers today. First, we have Rose MacKenzie, and Rose is the clinical manager for Mira Health. And we also have Dr. Carrie Jones, who needs no introduction. She is an author. She is a world-renowned speaker and educator, one of the foremost experts on female hormones. So I am going to turn it over to them and go off camera.
Sandy, thank you for that introduction. And I'll speak for Carrie that we're both excited to be here. We know we have a lot of information to go through, so we're going to try to go through as much as we can, but we probably will not get through everything. Please put questions in the Q&A. We also have a staff member on the backside who's going to be trying to help organize those and keep track of them for us as well. So again, we will jump in knowing that we have so much to talk about because there is so much about women's hormones that we could talk about. So we were already introduced, but here's our quick bios as well. And as you can see, full agenda. Let's start with the importance of women's hormones in women's health. So why does it matter that we know someone's hormones when we're talking about a woman's health? So I'll just give a quick little intro and pass it over to Carrie that we know as women, we are different than men. We are different because we have hormones, and those hormones have to be taken into consideration when we think about someone's health. So Carrie, I'll let you kind of introduce us to this all-encompassing why women's hormones matter.
Oh my gosh. And they matter so much because, hormones make the body go round. We have over 50 hormones in the body, and they do not work in a silo. As you can see from this picture, that in all the systems, they absolutely communicate. I mean, you might be thinking about the reproductive system with, ovaries and testes, but then of course we get into the endocrine, but more the like pancreas and blood sugar and insulin and how that relates. And then you're talking about their stress. And of course, the stress can absolutely drive up blood sugar, and it can tamp down testosterone, tamp down progesterone, and interfere with ovulation and sexual function. And then the thyroid gland gets involved, and the thyroid gland is like, well, now you're all running amok. I have to step in and do something. And suddenly it's this entire cascade, this like maybe it's a domino effect that can happen where they come to you and say, I am tired. I'm not sleeping. I am gaining weight. And these hormones being extra sensitive, they react to each other and then to everything going on in the environment and in their life. And what's so great is that there's so much we can do. There's so much we can coach them on. But when you take a step back and see how interrelated it is, it's not just the adrenal gland, right? It's not just their blood sugar. It's not just how do I talk to them about their thyroid. It's how do we talk to them about everything and how it's interconnected.
So if we think about how the women's hormones change, we have to know what they're doing and when they're doing it. And so I think it's you, Carrie, who I watched you in a presentation. It shows like the male hormones is, like one, and then the woman's is a roller coaster.
Yes.
Yes, I love it.
Yes.
So I didn't use the roller coaster picture here, but hopefully you can see, the female reproductive hormones do change and they're expected to change. And so a stagnant level would actually be a problem. And so we have to understand what these hormones do, when they do them, so that are they doing the right task at the right time, and when they're not, then it's maybe time to intervene. Knowing, again, the back of our mind here, it's not just hormones by themselves. Hormones of the reproductive also interact with all the other hormones. So that interconnectedness matters. And so let's start with how could we track women's hormones before? So historically, we had the ability to track hormones in samples that were collected and maybe mailed in. So saliva, urine, we had snapshot in time blood tests. Some patients were tracking their hormones indirectly with things like basal body temperature or mucus tracking. And so these were the ways that women could track their hormones historically. But now fast forward, as patients deserve it, they are demanding better things. How can I track my hormones better? I don't want to go to the lab every week and get my hormones drawn. I don't want to have to wait for the results. And so researchers started looking at, well, what's another way we can track hormones? And so we have now direct measurements of urinary metabolites in an at-home setting. So it's ongoing, remote. It can be done up to daily. And we're really able to see how patients are now responding to different interventions and, lifestyle changes, supplements, what they're changing in their lives, how is it affecting their hormones. So we go from a patient who says, my cycles are regular, and they open up their phone app and their period tracker, whatever they're using, says my cycles are 30 days. Now we can actually look at the hormone patterns within that 30 days and see, are the hormones balanced, coordinated? Are they triggering ovulation at the right time frame? And then are the hormones within optimal ranges? So much more in depth than what we could do before. So you're probably thinking, well, what's the benefit of doing all that? So hormone tracking, again, really, hormones should not be assumed that they're fine. Just like we don't assume that our cholesterol is fine, we don't assume that our blood pressure is fine. We really need to ensure that our hormones are doing what they're supposed to when they're supposed to. So we can check that and see. So you can see trends over time. So what am I right now? But then what am I as I do interventions? Maybe there's been a change in situation. So the hormones were fine, but no, they're not. So we can see that evolving and changing. Can also be useful for timing interventions in a cycle. When we'll go in a ton of chart examples of this. So this is just overview here. But timing interventions, timing other tests, and patient engagement. So I don't know, Carrie, if you want to jump in with any of these, but we're going to talk about a lot of this for the next.
We are. One of the things that Rose and I talk about is that how it's the combination of you get to see the entire forest and you get to be up close and look at a tree. So for example, if you just do a 1-day test, that's amazing, but you're also just seeing the tree that particular day. But if you step back and you can test every day or just about every day, now I can see the whole forest. And as Rose said, you can see, did all the things kick off in the follicular phase up to ovulation, and then the luteal phase, how did the luteal phase play out? And this is nice because sometimes, and I'll give you my own example. I do collect my own Mira test, and I ovulated. My follicular phase looked great, but my progesterone on days like 15, 16, 17, 18, 90, super low. I was like, where is my progesterone? Why has it not kicked off? Finally, on day 21, it kicked off through the moon. It was like this super sharp peak that went up, and then it came back down day 22, 23. If I had just gone to a lab on day 19, if I had just done a 1-day test on day 19, again, looking at that one tree, on that one day, I would have thought, I don't ovulate. My progesterone's really low. But when I stepped back and I could see it all month long and look at the whole forest, I saw I do ovulate. I do make progesterone. It doesn't hang out as long as I want it to, but I do make progesterone. And that's really a nice bonus to have when people say to you, I'm estrogen dominant, or I don't ovulate, or, my hormones are a mess. Well, now we can look at the individual days and then collectively as a whole month.
Right? So you are buffering a little bit. I hope it goes away. But we're back.
Okay.
So the situations that we typically see being used for clinical settings, we have them listed out here. Most common, of course, fertility. People automatically, when you say, I'm going to track hormones, they immediately think someone's trying to get pregnant. They're trying to time intercourse. But it's much more than that. As we discussed earlier, women who have ovaries that cause hormonal fluctuations really are, again, dynamic. These hormones change, and we have to consider that within anything else that we're doing. So if we're managing their thyroid, we have to consider the hormones. We're considering their cortisol, we have to consider the hormones because they interact with each other. And so, although I've written these things on this list, really it is, I like to say, anybody from puberty to menopause who has ovaries that still function. That is what hormone testing is helpful for. So I've given some examples here, but again, it really is all encompassing anyone in that time frame from puberty to menopause. So let's start basic. So using hormone tracking, can we identify and assess enough to answer the question, is my patient ovulating? I think that's where we all need to start with any client that's in front of us. Are they ovulating? And notice I did not say, are they having a period? Because that does not equal ovulation. And so again, oftentimes people think, well, I don't really care if they're ovulating or not. Are they having a normal menstrual period? But if they're not ovulating, then likely you are not having normal hormones either. And so a bleed in and of itself is not an indication of health. It's actually ovulation is more of the sign of health. Now, can we use bleeding to indicate health markers? Yes. But from this standpoint, I would like to change our perspective that it really is much more about, is the hormones coordinated to cause ovulation or not? So let's look at this first basic chart. So this patient we have began testing here. You can see the chart starts cycle day 1, May 5. We start testing consistently right in here. And what we're looking for is coordinated estrogen with an LH surge and then progesterone changes. Those are the 3 interactions we're looking for. So again, I told you we were going to start basic, but I already identified problems. This person has hormone problems. But let's look at some of the basics. So we got some hormone testing done. We find the LH surge. So that's this big spike of green right here, greenish blue, turquoise. So we have this trigger to ovulate right here on cycle day 14, 15, or if you prefer the day of the month, May 18, 19. So we get the trigger. We do see progesterone changes. So it's an ovulatory cycle, 29 days long. Great. We have some basic parameters. But you can do much more than that. As I kind of already alluded to, there's a problem with these hormones, and we're going to look at those in the cycles to come. So not just identifying ovulatory cycles, but are there problems within that cycle? So again, I'll leave this one here for now. We'll start with a basic chart. Okay, back to the initial question. Is my patient ovulating? So I have here 2 50-year-olds. Patient on the left is ovulating. Patient on the right is not. How do I know that? So let me draw my little pictures again. Patient on the left has coordinated estrogen is rising. We have an LH spike and her progesterone changes. The 3 key pieces of an ovulatory cycle. Patient on the right has all the estrogen. That's the black lines.
All of it.
All the estrogen, but no LH surge. So turquoise line, no spike, no progesterone. Look at her progesterone here. The purple is just flatlining. Oh, she got a little blip, flatlining. So ovulatory cycle on the left and ovulatory cycle on the right. So both patients are having bleeds. One is ovulating, one is not. So how we approach this, or how we take care of them, how we coach them, is going to be very different once we can answer the basic question. Are they ovulating? Carrie, did you want to add anything on this one?
I definitely want to add that women over 50 can still be ovulating. There's a lot of assumption that women over 50 don't, that they're, that's too old, they've stopped. But as you can clearly see, this is why testing is so important, because you may assume as a coach, like, she's kind of old, she's probably not ovulating. And look, the one on the left is absolutely ovulating.
Yes. And again, we are not going to go deep yet of the problems in these hormone patterns. We'll get
we
to
didn't
that
say
later.
they were great. We're just saying the basics.
Yes. Just identifying the basic, answering the question, is my patient ovulating? So then we move into this next one. I love this one because myself as a practitioner previously, when a patient said I had a bleed and then I bled 2 weeks later, I'm having periods twice a month, my cycle is only 18, 19 days long. I was like, no, it's probably anovulatory or it's breakthrough bleeding. I didn't always quite know, but I kind of assumed. And really by tracking the hormones, we as clinicians are being challenged on the assumptions that we make at times. And so this cycle, we see, again, a very early rise of estrogen. So let me get my little drawer out again. So rising estrogen really early in the cycle. We're on cycle day 3 here. So she's bleeding and having estrogen rise. She gets her trigger to ovulate here on cycle day 5. And her progesterone changes. Again, those 3 dynamic changes indicating an ovulatory cycle. So she is having a 19-day cycle that is ovulatory. Normal? Absolutely not. Do we need to fix things? Yes. But again, to answer that very basic question, is my patient ovulating? I can now say yes. Surprisingly, this patient had an ovulatory cycle. Okay, let's move to a little bit more complicated per se. So this patient has had a hysterectomy. So no menstrual bleeds because she doesn't have a uterus, but she sells her ovaries. And so do we know if she's ovulating? Again, you might be thinking, well, a patient had a hysterectomy. No, she's not ovulating, but that's a wrong assumption. This patient is ovulating, and I can see that quite quickly. Again, those 3 key things we're looking for: rising estrogen, an LH surge, and changes in progesterone. Those 3 key pieces are evident there. Now, this patient does not have a bleed. So in the app, she did kind of mark where she thought her bleed was. She can either do that or she can mark that she doesn't have periods. Either one is fine. And we can, again, identify quite quickly, is this ovulatory? or not. So this could apply for patients' hysterectomy, uterine ablation, even IUDs. Surprisingly, patients don't think that they can ovulate with an IUD in place, but yes, they can. I know Carrie and I have presented about that before.
Yeah.
We'll see if we have time to go into, the weeds of that later. Here's that cycle of the IUD. Again, shocking, I know, for everyone. This is an ovulatory cycle with a Mirena IUD. So rising estrogen, LH surge, changes in progesterone. Okay, so now let's go a little bit deeper. So now we've identified if they're ovulating or not. Now we want to really assess this. So let's start with our first patient. She has regular cycles that are about 30 to 33 days long. She's 40. In her situation, she's trying to conceive, but ultimately it doesn't matter. This patient could be saying those things Carrie mentioned at the beginning. They have fatigue, they just don't feel well, they have these new symptoms, and they want to know, is it hormonally related? So let's establish the baseline. Patient starts testing here when her period, starts, August 27. She starts testing consistently once her period slows. So over here, it's cycle day 5. And what are we looking for? Coordinated changes in estrogen with an LH surge. So I see the LH surge here, right here, cycle day 18, 19. But where is the estrogen? So let me draw what estrogen should look like. This should be something like this, rising, falling, second rise. So that's what her estrogen is supposed to look like. As you can see, she is missing that estrogen. The second thing is the progesterone, this purple line. You can see a little change right here, not the correct shape. Let me change colors. Progesterone should look like this, a bell curve of progesterone.
I would argue it should even be higher.
Now let's go higher.
There you
like
go.
This.
Lots of progesterone.
How about this? Somewhere in between here is where we want her progesterone, something like that. And so for this patient who, again, in this situation, she's trying to conceive. She's having a regular cycle at 32 days long. She's even having the trigger to ovulate. And so she may be thinking, my hormones are fine. Why can't I get pregnant? When we actually see these hormone values, I can see potential problems that are making it much more difficult to conceive. Lack of follicular estrogen. So again, I'm concerned about follicular development. Are we building up the uterine lining? And then where is that progesterone? That's supposed to be maturing that uterine lining, getting it ready for implantation. And these things are likely related, right? Poor follicular development creates a probably not as good quality egg, and then a poor corpus luteum afterwards.
And what happens? Oh, go ahead.
No, go ahead.
I was going to say, in cases like this, she may come to you and say, I've done an ovulation predictor kit. I went to the pharmacy, got an OPK, got an LH test, and I get positives, but I'm not getting pregnant. And now we can see what's going on.
Yes, because her LH surge is right here. It's very clear. She would have gotten positives.
Mm-hmm.
And I'm ovulating. LH is a great hormone to track. I love LH. However, it is not, what do you call it, Carrie? One trick pony. FSH. FSH isn't a one trick pony. LH isn't a one trick pony. They have to be coordinated with the other hormones and doing the right thing at the right time. And so patients with, we'll go look at some charts later of like PCOS, for example, where LH is abnormal. So then it makes it very difficult to just track LH because it's not telling you anything at all. At least this patient knows, okay, I'm getting LH surges, but that's not the whole picture. And this is not optimal. We have, again, a lot of work to do to optimize this. So often people ask me, well, what's the problem? Where are her hormones? I wish I had a very simple if this, then this, but that's just not how hormones work, and that's not how our bodies work. And so this could represent hypothyroidism. This could represent high cortisol. This could represent over-exercising, under-eating. But it helps you to identify that you have a problem that you have not found the root cause for. And let's say you find something, you find she has hypothyroidism. Great. You treat her hypothyroidism with, in your situation, maybe we're giving some supportive supplements to support her thyroid. And then we see her mirror data change. And we're like, great, it worked. Data doesn't change. Maybe there's multiple rocks that we have to look under and try to improve and see how she responds to those different interventions. Okay, moving on.
All right.
So I want to give what estrogen is supposed to look like. Now, I know you've seen my awful drawings on top of these charts, but this is what estrogen is supposed to do. So when you're looking at, is my patient having changes in estrogen like I'd expect? This is kind of the pattern as I keep drawing for you, this rising pattern, and then it falls, and then we have a second rise. And so when we look at that on top of a chart, let me flip to the next page. This is another representation of an abnormal estrogen pattern. Now, this one is completely different than the last one. This one, we have great rising estrogen here. You're like, her estrogen's great. But we also have to consider what estrogen is doing after ovulation. So this is a luteal phase problem with estrogen. And so we see here, instead of it dropping off and having a small second rise like this, we have this big mountain of estrogen over here. So let's talk about a patient or client who may have found this previously. That might be the person that comes to you and says, I have estrogen dominance. Okay, so this patient probably had blood work or another test that told her at one snapshot in time her estrogen was too high. That's true, but it's very important to see that this is not just one time frame, like 7 days after ovulation. This is her entire luteal phase is much too high of estrogen, but her before ovulation is just fine. So I would actually like to sometimes challenge that this is a phase-specific estrogen dominance. So this patient has estrogen dominance in her luteal phase, not just too high of estrogen all the time. Any comments on that one, Carrie?
I was going to say, I think it's important, especially relative to estrogen dominance. When we talk about estrogen dominance, is estrogen dominance relative to progesterone, but you can see her progesterone is fine. It gets the big purple leap that's up there. But with all that estrogen just in the luteal phase, whatever you're coaching her on with supporting her estrogen and trying to lower it, as Rose said, it would just be in the luteal phase. She seems to be doing great in the follicular phase.
And again, that's really why we need to know the entire thing, right? And maybe this client in the past did have too high of estrogen, but this can be improved. And as you improve it, you will see the correct, say one mountain instead of two. So this patient has 2 mountains of estrogen, and I really would like to see one. I'd like to see this up, down, and a small bunny hill afterwards. And so as we see improvements, I really would like to see that shifting. Okay, so let's talk about that progesterone pattern and keep drawing. So progesterone is supposed to rise after ovulation. Now I'll give a quick little caveat. Progesterone can surge as the patient's ovulating. That's normal. So we can see the beginning of this chart here, there's a little blip or temporary rise of progesterone. And then often we see a decline and then this rising pattern. And it rises generally over like a 3 to 5 day time frame. And so this can be really helpful for a client that goes to the lab and maybe they went generically on cycle day 21. And cycle day 21 maybe was only for them right here, 2 days after they ovulated. And then it might make it look like their progesterone is too low, when most of the time we're really looking for progesterone once it's hit its plateau. So somewhere in this time frame when you see that progesterone is stabilized and plateaued high. Now, a quick explanation. This chart are patients who have conceived. And so that's why you don't see the end of the bell curve like this, because they have successfully conceived in this cycle. So, but this really will hopefully illustrate to you that we should be getting, if we're doing blood tests or another type of more we'll say in-depth testing, it really should be done during the plateaued or expected high progesterone. Most of the time I hear that between 5 to 7 days after ovulation. I could argue here that sometimes it takes a little bit longer for the progesterone to get as high as we want, so 5 might be a little early. But it can really help, again, to time that test correctly. I'm sure Carrie has comments on that, but I want to show this chart while you start talking about it.
Yeah, well, I was going to say we probably see it all the time where maybe somebody says to you, again, I did go to the lab or I did my at-home test on day 19 and it came back quite low, but really it was still starting to rise. Or maybe they thought they collected too early. They thought they ovulated on day 11. So they started collecting on day 15. But maybe they have a luteal phase defect, so to speak. And so you can see by now forest through the trees. So they're spending money to get blood testing or to do a one-day test and getting not the full story, not the full forest. They're just getting one tree, and the tree is true to that day. Their progesterone is that value on that day, but you needed to see the day after and the day after and the day after and the day after to really see the full picture.
So let's use this one as a chart example. So this patient ovulates a little bit later in the normal time frame, so it's like cycle day 19, 20. And so if she would have went and got her blood test here on the generically cycle day 21, her blood test probably would have been low progesterone or even said you don't ovulate.
Yeah.
And that would have been very confusing to someone who's like, well, I get regular cycles. They're always 34 days, 35 days long. How could I not be ovulating with regular periods? When this test actually probably should have been done, again, if we count 7 days, that would be 1, 2, 3, 4, 5, 6, 7. Cycle day 27 would have been the appropriate time frame to get a mid-luteal progesterone check. Now, for this particular patient, you still would have found low progesterone, but it helps to make sense now. This client does have low progesterone the entire time. This purple line is well under what we'd expect to see. Again, this like purple shading here is where I want to see her progesterone get to, and she is much too low. So this is ovulatory cycle with low progesterone. So yes, can you have hormonal imbalances and still ovulate? Well, yes, I would say most hormonal imbalances, patients are still ovulating, but that's not saying that the hormones are optimal or ideal, and they should not live with them just being like this.
I actually had, Kate, if you go back for a second, Rose, I actually had a case. She used to work for me years and years and years and years ago. And she said, Carrie, my husband and I are trying on day 13 and 14. They were trying to get pregnant for a long time. We've been trying on day 13, 14. Our doctor keeps telling us, try on day 13, 14. Make sure you're trying on 13, 14. And I said, well, is that when you ovulate? She was like, I don't know. Turns out she ovulates on day 18. So she was missing the boat. And even though we know that sperm can last in fertile mucus for up to 5 days, it wasn't working for her. So when she shifted to be more like 16, 17, 18, as opposed to 13, 14, boop, she got pregnant. And we can see here, this is a great example, cycle day 19, 20. So if this was your client and they said to you, we've been trying forever to get pregnant. We try on day 13, 14, just like the books say. Well, they're missing the window. This is also an example. Let's say you have a client that's using natural family planning to avoid pregnancy. So they avoid day 14, 13, 14, 15. They avoid it. And then maybe they're intimate after the fact. Well, ovulation's day 19, 20.
We really need to know where ovulation is happening. We
Yes.
really need to know.
Yes.
And
we all have that friend. We all have that friend
Yes.
that, thought they knew their body and poof, got pregnant. And it's usually with twins.
Yes. So I think that really highlights the point of the cycle length does not indicate when someone ovulates, because often someone will say, well, my cycle is 28, 29 days, so I must be ovulating around day 14, 15. I don't know if I have a good chart for that moving forward, but we'll see. But there can be patients who have a 28-day cycle, but they don't ovulate till day 20. Now, that's a hormone imbalance. That's not going to lead to good success rate of conception anyway. But we can't assume that we know when they're ovulating. So going back to that question, do we know if they're ovulating? And then do we know when they're ovulating? Okay, so this one is one of my favorites because, again, I think often we don't think this can happen. So this is a patient with PCOS. And again, often patients with PCOS have long irregular cycles, although I don't like to overgeneralize that because we can have people with PCOS who have very clockwork cycles and their hormones are still a mess. But in this particular case, this patient's data, when we start testing, we see that she has, again, rising estrogen, what we like to see, yay, like check a box. We get the LH surge, great, check the box. But we're missing this mountain of progesterone here. Where is it? It's not happening. And so what did her body do? Well, her body did not ovulate. It's an LH surge that did not successfully trigger the ovary to release an egg. So there's no corpus luteum to make progesterone. So in this case, her body actually tried again. So this is not just a long cycle, long follicular phase. This is actually a distinct event called the non-ovulatory LH surge where the body tried twice. So again, failed here to ovulate. So it tried again, another rise of estrogen, black lines rising beautifully. We get this big surge of LH. And I know you're probably looking and you're like, why does the LH look so funny? The LH is biphasic, so you see it spike up, come down, come up, and back down again. There's a couple of reasons for that. Hormones are pulsatory, but also she's testing a second time in the same day, so her urine sample may be more diluted. So I am fine with this drop of LH and rise again. It's much more about, did this trigger successfully trigger the ovary or not? And in this case, it did. So this second LH surge here triggers the ovary successfully. I see this big mountain of progesterone. So now I know that she has ovulated. So let's think about this from the patient's perspective. Maybe they were using LH test strips and she got her positive right here. And then, 20 days later, she's like, where's my period? How come my pregnancy tests are negative? What is happening? It really can help our clients understand what's happening when they can see the data like this. Now they're not in the dark. They know that their body tried really well, actually, right? Nice rising estrogen, a nice LH surge, but it just didn't work. So then the body had to try again. And so let's say they were trying to get pregnant. They had intercourse on some of these days. Great. It's not going to work. She didn't ovulate there, but they timed it correctly. She can still try again over here, have timed intercourse again during the next rise of estrogen, the next LH surge, and potentially still conceive. Comments, Carrie?
Yeah, I want to add that this doesn't necessarily only apply to women with PCOS. You can see this in perimenopause as well. And so because as Rose said, these are pulses, the brain is trying to communicate down to the ovaries, to the follicles. And if there's miscommunication, lots of pulses, the follicles aren't listening, and then they listen. It was described to me like trying to get ketchup out of a ketchup bottle. Like the brain is smacking the bottom of the ketchup bottle and like a little bit comes out. And you're like, no, I need more for my French fries, more. And then you like smack it again. And then it's like out all the ketchup comes. And that's what it can feel like in perimenopause as well. So this can also occur at that age in that clientele.
Yes. Yeah, that's a great point. I think there's a lot of misinformation around perimenopause, which I think both of us are trying really hard to educate well around perimenopause. But it's not the two extremes. Sometimes I get told, well, all the hormones are low, there's no point in testing them. Or other people say, well, the hormones fluctuate too much, it doesn't matter, don't test them. And I like to say neither one of those is a absolute.
Yeah.
Could the hormones be low? Yes. Could the hormones be high? Yes. Could they be fluctuating? Yes. But do you know which one of them is happening? And so my argument is this is the best time to not assume what the hormones are doing, but instead test them in perimenopause. So.
And going back to the analogy of a forest, like this is a great forest to look at. You're looking at the entire national park right here, and you can get so much information. 2 LH surges, second LH surge brings on the corpus luteum and the progesterone. How cool.
Hey, that's the perfect lead in to perimenopause, right? So this is a 49 female who has irregular cycles, and her chart, actually, it's too big to fit on the page. So we pick up chart on cycle day 11. So we're already 11 days into her cycle here. And what do we see? Generally, it's fluctuating, but kind of flatlining estrogen for the first 2 weeks. And then we get this mountain of estrogen here. So to go back to the ketchup analogy, too much estrogen. I like to say this is when the ovary is like, I'm not done yet. And it decides, oh, sure, I'll give you some estrogen, a whole mountain of estrogen. And so this can help explain why symptoms can change, of course, for the client who's maybe she was doing okay, or maybe she was doing really bad. And then all of a sudden her symptoms change here when the estrogen significantly changes. And I think Karen and I have spoken about this before, but this high estrogen, kind of what could the patient be experiencing with that almost 4 weeks of a high estrogen?
A lot of women will tell me that their breasts hurt, their breasts feel full and swollen. They feel full and puffy. They feel moody, especially more depressed or anxious, even rageful. We often associate that with progesterone, and her progesterone is low. That's the purple flat line down there that Rose is drawing. But relative to estrogen also plays a major role in, how it triggers or stimulates neurotransmitters in the brain. The interesting part, too, is a migraine sufferer myself, on the shift of estrogen up and the shift of estrogen down, she might tell you her migraines are worse because shifting estrogen plays a shifting role in serotonin and then the trigeminal nerve in the head. And all of a sudden she has a right-sided or left-sided migraine. And so she starts to tell you these symptoms. You see the forest and you're like, that's a heck of a forest. Look at that. And it's a shifting forest. No wonder you don't feel great.
Yes. And so I did not put more perimenopause examples in here for the sake of time, but we have, Carrie and I have done a webinar that's recorded that you can watch later if you want to, of just more chart examples on perimenopause, because in the very beginning, I showed those two 50-year-olds side by side, one's ovulating, one's not. Mm-hmm. And then I showed this one with high estrogen, but we have other cycles with low estrogen for half the cycle, like basement low estrogen, and then the same mountain. And so there's a lot of different things that can happen within these perimenopausal cycles. And we never just want to assume, oh, that's what's happening to you. We really want to show, again, for the user, but also for you as their coach, to be able to see, okay, that's why maybe we were doing okay you're like, they were doing great. What happened? Well, their hormones changed on you. And I know it's not fair, right? It's not fair that we have this moving target, but we can actually see how the hormones are changing. So this moving target we can keep up with, instead of, again, that kind of blanket statement, well, we can't test the hormones, they change too much. That's not true. We can test them and see what's happening. Now, I did see a question in the chat, actually several of them that I have not been seeing. So let's go over a couple of them quickly while we're on perimenopause here. So the first question was, how does this help with perimenopause and menopause, and what about HRT? So I'll start by saying hormone tracking is best suited in this kind of ongoing, being able to see what's happening from puberty to menopause. Once we are postmenopausal, there's less utility because the hormones are generally low. And yes, they could be changing because of what you're, let's say they're on HRT, but there's less use for consistent ongoing testing. So are we researching utilizations? Yes, but at this point, I currently say postmenopausal is probably not your best bet for this sort of ongoing tracking. Any comments about that, Carrie?
Yes, I was going to just say, as somebody who is in perimenopause and uses Mira, and a lot of my colleagues and friends who are perimenopausal and using Mira, it's been a lot of help and feedback, immediate feedback to see what's going on. Even with hormone use for timing, if somebody is using, let's say, biphasic or luteal phase progesterone, and they truly want to wait until after they ovulate or to know if they're in the luteal phase, then testing gives that information. Or just as that last case showed, let's say she is perimenopausal and she says to you, I feel horrible. I feel the worst I've ever felt. And then all of a sudden, I had all this energy. I felt so much better. Like I thought my period was going to come, but it didn't. And then we see the chart and we're like, well, we can see what happened. Here's where you're at. The ketchup bottle exploded of estrogen. And to give a woman that information is so helpful, because she's already oftentimes feeling quite crazy in this time of life, just because the education hasn't been there for all these decades. And to have this so she can see it real time is so wonderful.
I see a question in the chat about testing consistently. So that's actually one of the beauties of this sort of testing. They're not required to test any specific way. Some patients will test, let's say, 3 cycles right in a row, and they want to test daily. Great, you do that. Someone else might test, get a baseline, and then they pause because maybe they're stable now, or they're working on all of their interventions, and then they want to pick it back up afterwards. So there's no requirement for a certain amount of testing, how long you have to test. Do we give some helpful tips and tricks? Yes. Like I generally say, it's very helpful to see 2 cycles if possible, because, well, you want to know, is that the one you just saw an outlier? Is that the odd one, or is this repeating itself? So 2 cycles is really helpful. Or someone that doesn't have cycles, again, that hysterectomy, then I say, we're looking at, you can just do weeks. I'd like to see, 6 to 8 weeks of testing to really see what is happening. So you don't have to think about it within cycles, but you can do weeks instead. So hopefully that answers the questions of like how often do you have to test, that sort of thing. Clients can just follow what the app prompts. So that's a perfectly fine thing to say. You just tell the client the app will prompt you how to test. Great. That's one option. Or you can say, I'd really like you to test this specific way. So one kind of tip and trick I give people is if someone has no idea when their last cycle was or how long their cycles are, maybe they're perimenopausal and they're like, it's very random. You can very easily say, just start testing every other day for the next 3 weeks, and then I'll chat with you and see what's going on. That'd be perfectly fine to do and say. If they want to test daily, great. You can do that too. Okay, let's see what other questions here. Carrie, do you want to take the what implications would like a health coach take to use this tool?
Yes. Oh my gosh. The amount of data that you have to now coach them. So let's say, I'm trying to think of our past case. Let's say you've got a fertility client. You've got a fertility client who comes to you. They're working with you on diet. They're working with you on lifestyle. And they're like, okay, we're trying days 12, 13, 14, all and then you get the Mira data back and they were the ovulator on day 19. Now you can coach them on, hey, let me explain to you how the menstrual cycle works. Let me explain to you that ovulation in the books happens on day 14, but humans don't follow the guidelines ever. We don't follow the book, the manual. So you actually ovulate on day 19. So let me coach you through that. Or now let's say you have somebody who's the high estrogen person. Like this is a good example, or one of the earlier cases where their estrogen in the luteal phase really quite high. And they come to you and they're like, I'm having breast tenderness, terrible PMS, heavy periods. We see their estrogen's high. Perfect way for you to coach them through detoxification, whether it's detoxification, food choices, how to support their liver, how to have a healthy gut, how to have regular bowel movements, how to support their bile. Perfect opportunity for coaching using this. Even in perimenopause, if she comes to you and says, I'm so struggling with perimenopause, I feel crazy. I feel like it's pure chaos. I don't know what to do. We see this case right in front of us. And now you can coach her and go, you're not crazy. Your hormones are, your follicles are, for sure. And then now, because she's looking at this and going, oh, thank goodness, it's not in my head. This is what's happened with my ovaries. Now you can absolutely coach her to be the things she can control, the things she can support, the diet, lifestyle, and exercise, and detoxification, and everything, community and joy, and etc. The like endocrine disrupting, avoidant, like all the things she can control. Very easily you can coach her on, but explaining to her menstrual cycle, like, okay, when you feel this way, and your hormones get like this, like here's what's actually happening. Let me educate you on how the menstrual cycle works in perimenopause. It's chaos. Here's what happens. Here's how you feel. And here's what we're going to start doing to mitigate. So there's so much you can do as a coach, especially, again, you're just going to educate to her what's happening in the forest. Here are these different hormones. Here's what they do. Here's what they ideally do. And how we hopefully need to course correct. Or let's say it's stress. Let's say the lack of ovulation, the lack of progesterone is because she's told you she's at a level 10 all the time, huge stress. So guess what? You're coaching her on nervous system support. You're coaching her on, best ways to handle her life, keep her head above water, sleep better. That's what you're working with on the coaching, given this information.
Yes. And so, let's see.
I can see more
Very-
questions that popped in.
Yeah, there's more.
Look.
I'm wondering let's get through the last section.
Yeah, I was like, I think we have one more section left. Yeah,
we
okay.
do. And then we'll get to more of the questions. I saw some
Okay.
about perimenopause, so I thought we'd pause for a second. So
Love it.
let's get into metabolic health. So I'd like to start this section with a study that was actually done out of the University of Toronto. And what they did was they took 49 participants who used Mira, Fitbit, and a CGM. And the goal of the study was to find if there was an association between glucose levels within a menstrual cycle. Because previously the studies were, some said yes, some said no, so there was no clear answer. And the researchers really said historically there's been some issues here. One, we were getting blood tests infrequently, so we didn't have a good monitoring of that glucose level. Secondly, those studies were using women's like recollection of their cycle. How long was your cycle last month? When was your period last time, and when did it just happen? And so we did not have a good representation of the cycle itself, and of course how it can change, because maybe you had a 28-day cycle last time, but this one that we're doing the study on was 35, and so it's a different cycle length. And so these researchers, again, use 49 participants. They plotted out the menstrual cycle here in percentages. So think of it as like a smaller version of phases. And you can see that there is a strong association with glucose changes based on the phase that the cycle is the woman is in. And so this really is amazing when we think about it from a health coaching standpoint, because when we know someone has high estrogen, so they're in that follicular phase, they're building towards ovulation, we know that that high estrogen is having changes on their metabolism, changes on their body. And so insulin sensitivity improves. So less insulin is needed, glucose levels are generally within range more often, and so we get something like this. So this is a real example of a user with a CGM on and using Mira at the same time. And you see her CGM, this is one day of a CGM just pulled out from that day, and you see the fluctuations with eating. So we see glucose mostly within target range. It does fluctuate with eating, but again, not these very large ups and downs. Now let's move to the luteal phase. So luteal phase, we now get very high levels of progesterone, which is great, right? We need high levels of progesterone, but there's pros and cons to hormone changes. A con to high progesterone is it causes a slight insulin resistance. And that makes sense because pregnancy, progesterone's kind of term the progesterone or hormone of pregnancy, right? Pro-gestation, pro-pregnancy. And so high progesterone decreases our insulin sensitivity, increases our insulin resistance, making us more prone to more fluctuations of that glucose. So go back to that same user. This is now her data pulled out from her luteal phase. Same person, same diet, different hormones, different outcome with her glucose levels. So she's out of target range more often. She has much bigger highs and lows. And I'm sure she is not feeling as well in her luteal phase. So when we have this information, we can now coach our users and say, you really should be eating differently in your follicular versus your luteal. And last webinar I did with Dr. Sarah Hill, she talked about how the calorie change that a woman goes through from follicular to luteal, how distinctly different that is. I don't want to misquote it, but I believe it's a swing of 200 calories. So 200 more in follicular, 200 less in follicular, 200 more in luteal. So I'll let Carrie chime in for a second. There's just so much we could talk about here, and there's more slides to come.
But this is again another. This is a like a validation when you have a client that says, "I think I'm pre-diabetic." Like I was told to wear a CGM, or maybe you are a coach for a practitioner who puts a CGM on everybody. Maybe you have a CGM on, and you're like, I failed. Like I have failed blood sugar, but then you realize you're in your luteal phase, and you do the Mira test, and you can see, oh, here's what's actually going on, and then we can work accordingly. Follicular versus luteal phase is so empowering.
So let's look at some more, because you might be thinking, well, that's just one user or one study. So here's just hopefully more evidence to prove this to you. This is a PCOS platform called Aspect, and they did a pilot with us. And you can see they do actual a score based on like how long the person was out of range, how high their glucose went, how long it took them to get back into range. And so it's a scoring system. And you can see, again, that the score, even if they did it a different way, still shows that the score is worse in that luteal phase. So it's not this person just fails at her diet in her luteal phase every month. This really is her metabolism changes because of that cascading effect of the hormones change her metabolism, changes how she responds to different foods. So for example, she may do just fine eating a sweet potato in her follicular phase, then she eats the same sweet potato in her luteal phase, and she does not respond as well. And so she can be taught, when you're in your luteal phase, maybe you have to have more protein or more fiber, or don't eat the sweet potato by itself. Things like that can be very actionable items, knowing what phase of the cycle she's in. One more chart example. This is, again, just showing this person actually has prediabetes. So she's got problems with her glucose the entire cycle through. You see her scores are all yellow, and then red is worse. So although you can't see like the same thing on her CGM, when they use this scoring system, they still saw worsening variability. So even if someone is kind of bad all the time, they're still even worse in their luteal phase. And so this really applies to everyone, whether they have no problems with glucose and insulin, or if they have severe problems, it still applies to them, or if they are having fluctuating hormones and still having ovulatory cycles with high progesterone. So that comes to really this matters greatly for any sort of interventions you do, whether you're talking to them about their diet, their supplements they take. Are they going to do things like seed cycling or things to support their hormones, or how they manage their glucose? Everything can be timed within a cycle based on that follicular versus luteal. Any comments, Carrie?
I was just going to say, I think, again, the more education that you have around this, the better. And honestly, it'll set you apart as a coach, because not a lot of people in the greater world are talking about this. It's a one and done. It's do the same thing every day, or it's do the birth control pill, or it's, something that's very generic. And this just goes to show how individualized and how personalized care is and coaching is. And having this data really drives that home and makes it so much easier to be personalized.
And if you want more information about how to personalize these things, there are programs such as like Alicia Vidi's cycle syncing. So I'm definitely not the person to teach you how to do this, but you can, if this is something you're interested in and you're like, yes, I want to help my clients live within their cycle. And of course, there's actual methods like cycle syncing. So this is, again, Alicia Vidi's work. She has an app called In the Flow, books as well. And so we did a webinar with her previously, and this is some of the information that she was sharing of like what's needed in the menstruation phase. And then when they move after menstruation now into their follicular, what's needed there, what is needed at the time of ovulation, and what's needed after they ovulate. And how this pairs beautifully with the hormone data is it doesn't matter if they have like a really long cycle like this one I'm showing here, which is 49 days long. Her follicular phase is way too long, but those interventions that you would be doing would continue well past just cycle day 14. It's not you do this for 2 weeks in follicular, you move to the next luteal phase 2 weeks, because that's not specific to your client. Your client is having a luteal phase that lasted all the way till about day 34. So they're stuck in that follicular plan a lot longer. But as they do interventions, they'll hopefully get their cycles more normalized. And again, it can be used for, this is an example of different workouts or exercise within the cycle syncing. And again, when we look at, this is that chart we showed earlier with that much too high of estrogen in the luteal phase. And so this high estrogen potentially can be adjusted and fixed by these lifestyle interventions. And as you do these changes, you'd actually see it improve. And last but not least, even if you have a very short follicular phase, so the first one's long, middle one's, normal, and then we have a very short follicular phase, very short. So it just shows again that we can do things within our phases of our cycle because we have the ability to track these. It's not outside of reach. It's not too complicated. We have researchers using our product to potentially be like timing medication doses and when they take it. And so, of course, you could do this with lifestyle and supplements and that sort of thing. So
thank you. That was outstanding. And I just want to make sure that you address a few questions that came in that were pre-submitted. And the first, now this is not the topic for today, but can you just quickly explain the differentiate between bioidentical versus synthetic hormones?
Yes, I can. I also want to make a comment. I apologize. My camera keeps glitching. I think my audio's in, but my camera keeps freezing. So I apologize. I think my camera needs progesterone today, quite honestly. So bioidentical is what the exact hormone that you make in your body. So for men, that's testosterone is testosterone. For women, we're looking at estradiol. We're looking at estriol. We're looking at progesterone or testosterone. DHEA. Same. The synthetic are, for example, progesterone. We talk about the progestin. So for the progestin in the birth control pill, progestin used in perimenopause or menopause, the progestin in the IUD, it's able to bind to progesterone receptors, but it doesn't look the same. And therefore it can come with a host of side effects. Even some side effects and things that we're not quite aware of yet. And the same goes for estrogen. We have synthetic estrogen in the birth control pill. The synthetic estrogen that can be used in perimenopause and menopause. There are actually two different types of estrogen. Again, they can bind to the estrogen receptor, but they don't look like estrogen exactly. Therefore, they can come with a host of side effects. So the bioidentical is sometimes called body identical because it's same. The body sees it the same. The synthetic, and some of the synthetics are tricky because they will have the name estradiol in it or progesterone. So ethinyl estradiol in the birth control pill is synthetic, despite the fact that it says estradiol. Medroxyprogesterone acetate, even though it says progesterone, is a progestin. It's synthetic for perimenopause and menopause. So even then, it gets a little bit tricky, but that's the difference.
Gotcha. And for somebody who has clients over 60, more than 10 years beyond menopause, and their doctor says no, what would you recommend? Any tools or research? What I would say is that coach could coach them to be their own advocate and find the best practitioner. I went on it at 74 a year ago, so there are providers who will assist your clients.
I tell people all the time, it's if you have a dog and you took your dog to the vet and you didn't like the vet, you would find a new vet. If you have a child and you took it to the pediatrician and you didn't like the pediatrician, guaranteed you'd find a new pediatrician. If your provider is not meeting your needs, especially around hormones, they're not aware of hormones, they're not up to date, that's not their area of specialty, that's okay. Thank you very much. You will find a new practitioner.
Absolutely. One more here. If you're breastfeeding still and your periods haven't come back, what would be happening with your hormones? And can you use Mira?
I will let Rose answer that, but I have thoughts as well. Go for it.
Yeah. So when someone's postpartum breastfeeding, they have high levels of prolactin that should be suppressing their hormones for a period of time. And it can be as short as 8 weeks to 2 years. So a huge range of normal there. But that's actually where the Mira would fit in really well, is you can be monitoring those hormones to see, are the hormones returning and are they getting coordinated? Because you can get kind of these little patches of estrogen, but they're not actually getting an LH surge to happen and no progesterone. And so they're not ovulating yet, but they may be approaching. So of course, we do recommend working specifically with a fertility awareness educator, a natural family planning instructor. The Mira as a tool is great for that use case, but you can't assume that you'll avoid a pregnancy without working directly with an instructor. So again, Mira as a tool, not a method in and of itself to avoid a pregnancy.
Thank you.
I was going to actually add in the ovulation piece, because women who are breastfeeding, the first thing they look for is their next period, right? They're like, well, I haven't gotten my period back. Everyone asks, have you gotten your period back? Not yet. What comes before a period? Usually ovulation. We all have that friend. Maybe it was you. You were breastfeeding and then you got pregnant and everyone's like, how is that possible? I didn't get my period yet, but you did ovulate, or they did ovulate. So if you knew, if you were tracking on Mira, you could understand ahead of time that you were ovulating.
Yes, I just heard the term for that is Irish twins. I'm not Irish, but I was with Irish people, and that's what they said.
The back-to-back, yes.
All right, we are out of time. If there are some burning questions that came in that you can quickly answer, if that would work for you, because we have some great questions, and I apologize for not getting to all of them.
Yeah, I can quickly answer. You were talking about how getting a second opinion. Mira did just develop a directory of providers that are perimenopause specific. So again, it's clinicians who use and understand Mira data, and it can be you if you want to be on that list as well. But you can find, maybe you have an OB in perimenopause, but you don't have an acupuncturist or you don't have a health coach. So you can, users can go find the right type of clinician for them. So I'm a huge advocate for finding a second, third, fourth, fifth opinion until you find what you need.
Well, this has been absolutely outstanding. I want to thank you, Rose and Carrie, for taking the time for this outstanding webinar. Thank you for everybody who attended. You will get a copy of the recording, and it was just been a pleasure to have you on our Ask the Experts. Thank you so much.
Yes, thank you for having us here.
Thank you.
Thank you. Bye, everybody.
Bye, everyone.